webinar today. Let me switch over to share my screen. It says host disabled screen sharing.
Oh, I got an idea for that. Hold on. I'm going to make you the co-host. So here you go.
Awesome.
Should be able to.
All right, let me choose the right thing here. Okay, Katie, tell me, is my screen showing up?
Yes, it is.
Awesome. Okay, welcome everybody. My name is Alex Mohseni. I'm an emergency medicine physician, and I'm the physician founder of CanaryDoc, that's CanaryDoc.com, which is a new practice that I just started providing a virtual clinic for Medicare patients in almost every state. And today's topic, what I want to talk to you guys about is for seniors and the geriatric population, helping understand when is it the right time to go to the emergency room, when is urgent care more appropriate versus seeing your primary care doctor, and how are you supposed to figure that out, whether you're the senior yourself or whether you're a senior serving professional or care manager. So those are the topics today. Please feel free to interrupt and ask questions as we go along. This is meant to be totally casual and learning for all of us. So briefly about my background, I'm a board certified emergency medicine physician. I have worked in the DC metro region's ERs for the last more than 10 years. I worked at Sibley for a number of years and Virginia Hospital Center, Reston, and a number of others. I have since transitioned to full-time telemedicine work, so I don't work anymore in any brick and mortar ER, and I'm licensed in 48 states. And actually, as of a few days ago, it became 49. I got Massachusetts finally. As I said earlier, I'm the owner of CanaryDoc, my new virtual clinic for seniors. And we'll be talking about that briefly later about what I do there. I'm also the medical director for AccuHealth, which is a remote patient monitoring company. And Dr. Amy Schiffman and I co-host the Mastering Medicare podcast, where we talk about all sorts of healthcare related and Medicare related issues for senior serving professionals. And those seniors who want to really understand Medicare on a deeper level. So thank you for having me today. And let's get into our talk. So briefly, I want to explain, touch on the kind of three most common types of care that any senior might experience. First, on the left-hand side is primary care. Primary care is generally a longitudinal relationship with a specific provider. These are usually scheduled visits. There's a great focus on chronic disease with limited after-hours capability, limited interventions that can be done in the office, and relatively limited diagnostics that can be done either through the office or outpatient labs. On the other end of the extreme is emergency medicine care, emergency care in the ER, which is episodic. It's unscheduled. It's focused on acute care. It's available 24/7. Almost every intervention and every diagnostic is available through the ER if appropriate and needed. And in between is this vague thing, which for many seniors is very novel and unfamiliar, and that's urgent care. So urgent care is kind of a mix of these two. It tends to be more episodic, unscheduled. It's more focused on acute care, but there is some basic primary care that can occur there. It tends to have extended after hours and weekend capabilities. There are more interventions and more on-site diagnostics than in a primary care setting. But what's tricky with urgent care is because it's in this gray zone, the quality of care and the scope of care that you can get in urgent care is highly dependent on the skill set of the providers there and the equipment of that facility. In the olden days, urgent cares used to be kind of these small mom and pop shops, but now with the advent of more of these corporate urgent cares like patient first and hospital-based ones, they're really more like small mini emergency rooms. So there's the scope of care you can get in urgent care is quite wide, and I recommend that if you're in the senior serving world, that you get a good sense as to what those capabilities of your local urgent cares are. I'm going to go to the next slide here. So one important point is that these three venues for care do overlap, and there are certain types of encounters that could take place in any one of the settings. So I want to highlight here, because for a lot of people, they really don't understand what the capabilities of an urgent care are versus the ER. And so I want to highlight some of those differences. So on the right, as you can see, the ER has essentially everything I've listed here, but let's go through them one by one, because urgent care only has some of these. So first is accessibility of more advanced imaging. So CT scan, MRI, and ultrasound. Those are all available in the ER. In most ERs, available 24/7. MRI is obviously more difficult. MRI studies, a typical MRI takes an entire hour to get done. So if you can imagine, if a hospital has only one MRI machine, if they're perfectly efficient, they can only do 24 MRIs in an entire day, roughly speaking. Urgent care is generally not going to have CAT scan, not going to have MRI. Some urgent cares have ultrasound, and that's, again, highly dependent on whether do they have the equipment, and then do they have somebody who can operate the ultrasound. These days, more and more ER doctors are being trained on performing ultrasounds themselves, and they're being trained on doing that in residency. But when you go to an urgent care, you might get a doctor who was trained as an emergency medicine physician like me, or you might get a family medicine doctor or an internal medicine doctor who never typically has not been trained to perform ultrasound. Ultrasound is commonly used for a few things. We use it to look at gallbladder. We use it to look at fetuses, and it's great for looking at the bladder. Getting a quick look at the kidneys, ultrasound is great too. And then certain versions of ultrasound can be used to look for blood clots in the legs. Those are kind of the most common uses for ultrasound. CAT scan is used commonly for head injuries, evaluation for blood clots and other complex things in the chest, and as well as evaluation of abdominal pain. And MRI is commonly used in seniors for looking for things like a stroke would be an acute use of an MRI in the emergency room. EKGs are typically available in both urgent care and ER. What's critical with an EKG is that the physician needs to read it and read it accurately. So again, somewhat dependent on the skill set of the provider you have. X-rays are available in both urgent care and ER. The difference is going to be that in an ER, typically the X-ray is going to be, so in both ER and urgent care, the ordering physician is typically going to look at the X-ray, him or herself, and give a preliminary report. In an ER setting, which is in a hospital setting, the radiologist will often give an official read, typically within an hour or two, whereas in urgent care, the official read from the radiologist, if it even happens, might not happen until the next day. Typically, that's what happens. I'll pause there for a second. Any questions thus far? Okay, Katie, interrupt me if there's any questions or if anybody wants to ask any. So on the lab side, yeah, ER has access to pretty much every lab you can imagine. In the urgent care setting, it's relatively limited. You're going to be looking at some basic kidney function, liver function, electrolytes, that sort of stuff. IV fluids, both urgent care and ER can provide IV fluids, no problem. Sedation. So this is an interesting topic. If you have a senior who has a significant injury and the bones are displaced, so they're out of alignment. Typically bones, when they're broken and out of alignment, what we call displaced, they need to be reduced. They need to be put back into position. As you can imagine, that can be really, really painful. And so oftentimes we'll offer sedation, so putting the patient to sleep to be able to tolerate such a procedure. This is especially important if you have a senior, for example, who has a hip dislocation or a hip fracture or a major injury to the forearm, which is very common when all seniors fall. They can have fractures in the arm that require reduction. So sedation is a high-risk procedure where you're giving essentially anesthesia to the patient. It's generally not done in urgent care, but can be offered in the ER. Next is advanced airway techniques. So if you have somebody who is having an airway or respiratory emergency, the urgent care is essentially never the right place to go for that. As you guys hear with COVID-19, you know, if somebody's having difficulty breathing or being oxygenated, they're a candidate for being placed on a ventilator. To be placed on a ventilator, you need to be intubated. You need to have a tube placed through your mouth into your trachea. As you can imagine, this is like putting a garden hose down your mouth. This is extremely uncomfortable and can generally only be done in a comatose state. So you have to be given anesthesia essentially to so that you don't gag and rip the tube out. So that sort of stuff is just not available in urgent care. It's a very high risk sort of procedure. So if you have somebody who has a significant respiratory complaint and is fragile and could quickly go downhill, then urgent care is not going to be the place for you. IV medications, typically urgent care is going to have some limited access to meaning a limited scope of things they can give through an intravenous method and some intramuscular. The ER, of course, is going to have full access to everything. Life support, so being placed on a ventilator and some of the complex medications that are given with that. Again, urgent care is not the right place for that. And the last point I want to mention is access to specialists. So in the ER, you know, the ER is kind of the hub of this big hub and spoke system where the ER doctor can very quickly reach out to a specialist from almost any field for advice, and if needed, can even request that specialist come into the ER to help assist with a patient. And that's part of that specialist's duties. That's what it means to for these doctors to be on call for the hospital. That's generally not available through the urgent care. You know, some urgent cares have arranged some sort of specialist advice lines, you know, with a limited scope of specialists, but that full broad scope is often not available in the urgent care. So for example, I've had patients in the ER who have an ophthalmologic emergency. So they're having an emergency with their eye, for example, acute angle closure glaucoma, where you need to talk to an ophthalmologist urgently. That's very doable from the ER, but very difficult to do from the urgent care. Typically.
Dr. Mohseni, there
Yes.
was a question. Do urgent cares have CPR and AED capabilities?
Generally, yeah. So CPR itself means, you know, putting your hands on the chest, pressing hard over and over to try to pump some blood through, and AEDs to shock. For the most part, they're going to be able to do that. The question is, then what? What do you do with that? So they're generally going to call 911 and have an ambulance pick you up and take you to the ER. So if the ER is far away and urgent care is the only thing available, then yeah, go ahead. It's better than nothing. But that's not where you want to be if you're that sick. Good question. So how do you know if you need the ER? So ER has all these capabilities, right? But it has major drawbacks. There's long wait times. It's complicated. It's dirty. People are screaming and dying and vomiting all over the place. There's COVID-19 everywhere. It's expensive. You might sit in the waiting room for 6 hours. So how do you know you actually need that? And the test, oops, sorry, I hit the wrong button here. Is my screen still visible?
Yes. Yep.
Okay. So the test, if you need the ER, is if you could reasonably be having a life or limb threatening issue. So something where you might die if it's not diagnosed and treated, or you might lose a limb or an eyeball or the function of a limb or eyeball or something like that. So here are some obvious indications for going to the ER, but as we'll see in the next slide after this, there's a lot of gray zone, and that's where things get really tricky. So obvious reasons to go to the ER. If any senior who has chest pain, especially if the chest pain is new or different from what they've experienced in the past, shortness of breath, abdominal pain. You know, abdominal pain in a senior is can be extremely worrisome. And yes, it can be caused by something as simple as gas or constipation. But very often, abdominal pain in an elder person can be something extremely dangerous and life-threatening. You know, from things like intra-abdominal infection, like appendicitis, bowel obstruction, bowel ischemia, aortic aneurysm. The list goes on and on and on. And it's really hard to evaluate abdominal pain without a CAT scan in an elder. So, I just want to pause there for a moment on that point. You know, abdominal pain is a really, really tricky thing, and many dangerous things can cause it. Any sort of new neurologic symptom like altered speech, a change in ambulation, vision, or strength, those can be signs of stroke or other sort of vascular emergency. So that needs to go to the ER. Any sign or suspicion of sepsis or other form of severe infection. So sepsis is when an infection has typically spread and oftentimes to the blood, what we call bacteremia, and causing an acute inflammatory reaction where you might have a high fever, low blood pressure, and other signs of severe infection. What gets tricky is that in the elder population, seniors may not manifest the typical signs of infection. Sometimes when a senior has a severe infection, their temperature, instead of going up, might actually go down, and their heart rate might not be as elevated as you might expect in a severe infection. And that could be, one, just because they're old and the body reacts differently at older age. And sometimes it's because of interaction from other medications. For example, if they are on a beta blocker for some sort of heart disease or blood pressure issue, then their heart rate, because of the beta blocker, won't elevate in the natural way, and they might their vital signs might look better than they actually are. Any sort of heavy bleeding in seniors, especially rectal bleeding, which can present as frank blood, or it can present as black stools. So if a senior has dark black tarry stools, that's a sign of bleeding that has started in the stomach and mixed with the acid, and it makes it turn black. That is extremely dangerous, and seniors need to be seen for that. Now it gets tricky. Sometimes a black stool is just from taking now I'm blanking on these GI.
Or the, not blueberries, but the other berry, elderberry.
There are some berries that can do it, but there's also some iron-containing medications, I can't believe I'm blanking on this. But there are certain medications that one can take that might cause a similar-looking stool. So one of the first things that will happen if there's any suspicion of rectal bleeding is a rectal exam, where a piece of stool is tested with a chemical to see if there's actually signs of blood there. Any sort of symptom that's sudden or severe, you know, any sort of new sudden or severe pain or sudden or severe neurologic symptom, those are typically more likely to be something dangerous, and I would recommend going to the ER. Seniors who feel newly weak, dizzy, or lightheaded, this is an extremely common and very difficult thing to work up. There are many things that can cause a senior to be weak, dizzy, or lightheaded. It can be from low glucose, dehydration, arrhythmia, electrolyte abnormalities, neurologic abnormalities. So it's really, really tricky, and you need to do a very thorough workup and examination to try to figure it out. Now, there are folks who are always weak and dizzy, and that's okay, meaning if it's been worked up and it's the same as what they always have, that's one thing. But what we're talking about here is if there's anything new and you don't feel confident as to what's causing it, that needs to be evaluated. And then, as I mentioned, some fevers, you know, fever can be from something mild like some sort of just basic cold, but it can also be a sign of sepsis. So with seniors, because their ability of their body to react and fight off any sort of infection or insult to the body is less and weaker, you just have to be more cautious with this population. Okay, next is what I want to talk about here. See, what we just talked about, those are kind of the obvious causes for indications for going to the ER. But what about some of these things that I've listed here? You know, one of the things I've seen, you know, in my career is that there's a lot of folks who have a symptom that as a lay person, they don't necessarily recognize could actually be caused by something dangerous and life-threatening. And I want to touch on a few of these. This is, I guess, a little bit of learning, a little bit of medicine, but hopefully it's interesting for you guys. You know, so let's go through these. So headache, you know, obviously a headache can be something benign just from, you know, having stress or not getting enough coffee or something like that. But there are dangerous causes of headache too. There's acute angle closure glaucoma, which is also associated with eye symptoms. Temporal arteritis, which is an inflammatory process that can cause blindness very quickly. Bleeding in the brain. You know, old people, their skull stays roughly the same size as you age, but your brain starts to shrink. So what happens is then there's more stretch on the blood vessels in the brain, and any sort of kind of knocking around the brain can rip one of the blood vessels and cause bleeding in the brain. Or if there's actual trauma to the head, old people are going to bleed easier and sooner and in typically a worse way than younger folks. Meningitis can cause headache. Carbon monoxide poisoning can cause headache. So there are many different types of cause of headache, and some of them are dangerous. Back pain can be, again, something totally normal and benign, just like a muscle strain, but it can also be something dangerous and life-threatening, like aortic dissection. Aortic dissection is where the aorta actually rips. The aorta is the main blood vessel that comes off the heart. This is what killed John Ritter, if you guys remember, the Three's Company guy. Aortic dissection is often extremely hard to diagnose, very easy to miss. It can present with many different types of symptoms. Other possible causes are things like spinal cord abscess. So if you have like a diabetic senior who has a fever and back pain, that could be from an abscess on their spinal cord, something extremely concerning, very hard to catch. They're typically only found on MRI of the spine, which is, you know, not often available quickly and easily. Cauda equina is a neurologic emergency of the spine with a special presentation that typically involves some sort of new incontinence or numbness in the groin. Nausea and just generalized weakness can be a sign of a heart attack, aortic dissection, aortic aneurysm, sepsis. I mean, there are so many different things that can cause nausea and weakness in an older person. A cold limb. So if suddenly a leg or part of a leg is pale and cold, that could be from a clot in the artery, which is an extremely urgent thing that needs to be treated quickly. If you have a swollen, painful calf, it could be from a blood clot in the vein. This is different from the cold limb, which is a blood clot in the artery. And these are again, high risk. That blood clot can propagate to the lung and cause the next thing called a pulmonary embolism, which is a blood clot in the lung, which can kill you. And sometimes a pulmonary embolism can present with just a fast heart rate. You might not necessarily have chest pain or shortness of breath. Dizziness, as we said, can be a sign of stroke or atrial fibrillation or other arrhythmias. Dental pain, again, can be totally minor, or it can progress to a dental abscess, which then can spread to the face and the more dangerous parts that connect to the brain. And as you guys know, there's some horrific stories where untreated dental infections have led to people dying. Rashes can be, again, very benign, or they can be a sign of something much more serious going on, like low platelets, which increase the risk of bleeding, or it can be a sign of meningococcemia, which is a very dangerous type of bacterial infection in the blood. Numbness in the groin or around the buttock and anus area, especially if combined with back pain, can be a sign of cauda equina, which is a neurologic emergency. It can also, especially in a diabetic, be a sign of necrotizing fasciitis, which is, you guys have heard about flesh-eating bacteria, where it's a certain type of bacteria that just starts eating away at your flesh. That's more common in diabetics and other immunocompromised people. And what's really tricky there is that the patient themselves might not really feel much there. They might not necessarily feel pain in that area. Cough can be, again, something benign that could be just from your bronchitis or just a little bit of seasonal allergies, but it could also be from new or worsening congestive heart failure. It could be from a pleural effusion, so a collection of fluid in the lung. It can come from an arrhythmia sometimes. And my last example here is a red eye. You know, a lot of people think, oh, your eye's red, you have a little pink eye, just don't touch it, stay away from people. But a red or painful eye in an older person can be a sign of acute angle closure glaucoma, where pressure has built up in the eye, and if that pressure is not relieved urgently, blindness could occur. So the real message here is, you are not expected to know all of this, right? This is stuff that ER doctors know in and out. This is why we go through all of our training. My point here is that sometimes seemingly benign symptoms can actually be the sign of something more serious, which is why I created the practice that I created, where I'm basically available as an ER doctor, kind of like on call as a virtual urgent care. So essentially over the phone or via video consult, I'm here to basically talk to seniors, their family members, their caregivers, and see you through a relatively urgent visit, so I can listen to your story, ask you the appropriate questions, and say, okay, is this something that actually needs to go to the ER? Is there something we should be worried about? Or is this something that we don't need to worry about and we can take care of over the phone? Or maybe it's something that needs a little bit of attention from your primary care doctor, but you don't have to, you don't have to run to the ER right now. So that's what I've created. I've created a virtual urgent care where for Medicare patients, I'm able to give you the advice that you need to go through whatever symptoms you have, and to whatever degree possible, manage it directly, and to whatever the degree necessary, refer you to the right place to get the care that you need. So one of the things we touched on is that seniors, taking care of seniors medically is more challenging than taking care of younger folks. And as we said before, seniors don't necessarily present with typical or classic symptoms. For example, they might not have a fever with sepsis, and in fact, their temperature could be low. They're often on many different medications. Those medications can mask some of the symptoms. They have limited physiologic reserve, so they have less ability to respond properly to something that's attacking their body and do it in a quick and powerful way. They might have difficulties communicating, either because of dementia, or perhaps they don't have teeth, or who knows what. Many seniors don't manifest pain as much or in the same way that we might see in younger folks. And many seniors are also very stoic, especially from the World War II generation. They might not complain about anything because they don't want to bother anybody. So I'm providing care, through by phone, by video. I don't have a brick and mortar office. Everything I do is through phone and video. So I often get asked this question: what sort of things can I actually take care of by phone and video? So the first step, as I mentioned before, is to make sure that you don't have an acute emergency, or make sure that it's likely not an acute emergency. Because if we think, I think it's this, but I'm not sure because it could be also X, Y, and Z, and those are dangerous, then, oftentimes I'm going to have to say, okay, here's what I'm worried about, and there's no way for me to tell just by talking to you that you don't have X, Y, or Z, so I recommend you go to the ER. And if we do that, I'm also happy to pick up the phone and call the ER and give them a heads up that you're coming and what it is that we're worried about, which a lot of folks find very helpful. But for things that we can manage over the phone, if you have a minor illness, cold or cough, fever without signs of sepsis, minor injuries and sprains, a lot of these sort of minor, simple things we can evaluate, make sure we don't see any clues to anything dangerous going on, and take care of it directly. Many forms of sore throat and sinus infections can be managed over the phone and via video. Uncomplicated bladder infections can typically be managed relatively easily. Certain sexually transmitted infections can be managed. You know, bladder infection is an extremely common form of UTI, especially in seniors. And if caught early, it's relatively easy to treat with some oral antibiotics. But if left untreated, it can progress up towards the kidneys and then into the blood and cause sepsis and death. And so, again, UTI spans the spectrum from easy to treat to deadly. Certain rashes, pink eye, minor asthma, and COPD sort of issues can be typically managed virtually. And when there's certain abnormalities in blood pressure and blood sugar, that too can often be managed safely without needing you to go to a brick and mortar facility. And on that note, you know, one of the other services I do provide from my clinic is monitoring, what we call remote patient monitoring of blood pressure, blood sugar, and weight. This is a new program that Medicare launched recently and expanded the scope of starting January of this year. And with COVID-19, they've actually put out multiple articles basically reminding doctors and patients that remote monitoring is something that Medicare now pays for, and they're strongly promoting. And the idea is basically that the ordering physician, so somebody like me, can order a blood pressure monitor or a glucometer for a patient to use at home. And the service I use, we pay for that device, meaning the patient does not have to pay for the device. And what's cool about these special devices is that when the patient takes their measurement of whether it's blood pressure, blood sugar, weight, what have you, or oxygen level, then that result comes straight to my system, my platform, and so I can see it. So the patient does not need to call me or email me or text me with their numbers. That data flows automatically, so it allows me to keep a closer eye on those patients whom I'm monitoring. And this is typically something that you can do for months. So you can say, okay, you're somebody whose blood pressure, you're a little bit worried about it, it's maybe not optimally managed, or you just want to keep an eye on it because there's some family history of stroke or what have you. You might be a great candidate for this sort of monitoring. You know, the other thing that I want to touch one more point on the monitoring. So monitoring a physiological parameter like blood pressure and blood sugar is great in and of itself, right? But it has the added benefit that it creates a touch point between the physician and the patient, a more frequent touch point. So the cadence of communication is higher. You know, in the old model, you might see your doctor, once every 6 months or something, and get a random blood pressure at that time. But now with this sort of monitoring program, the physician's monitoring that data essentially on a daily basis. And if there's any questions or issues about anything, then the patient, through the monitoring platform, or the physician, they can get in touch with the patient a lot faster and easier. So there's just more communication, and that communication happens more frequently, which I think is better for the overall health of the patient. I get this question all of the time. What if the senior presents with something that you can't diagnose by phone? And again, this is one of the big points from my talk today. Even if I can't diagnose it 100% by phone or video, I can at least give you guidance as to what this could be, what you should or should not be worried about, and where you should go for care. And I think that is of value. And most of my patients and their family think that's valuable too. So it's not all just diagnosis. You know, one key thing that many people need is just guidance and reassurance. And I have this bullet point, abdominal pain examination by video, to remind me to talk to you guys about this. I had a case recently. There was a gentleman who presented with abdominal pain. And you might think, oh, you can't evaluate abdominal pain through phone or video. How are you going to figure out what he's got? So I asked him a bunch of questions, and I started to get suspicious that he has appendicitis based on where his pain was and what his symptomology was. And I asked him to stand up and try to hop up and down and tell me if he has pain and if he's able to tolerate doing that. And he wasn't able to do it. And he wasn't able to do it because his abdomen hurt too much. And that's a sign of what we call peritonitis. So the lining around the abdomen is inflamed. So I told him, I think you have appendicitis. This is a very good story for that. I'm going to send you to the ER and have them evaluate you. And I got a message from him later that day. He went there, they examined him. They agreed that it looked like appendicitis. They took him to the operating room, took out his appendix. It was appendicitis. And they sent him home later that same day, which that too is amazing. This is during the COVID-19 era. In the past, if you had your appendix removed, typically you'd be in the hospital at least 1 or 2 nights. This gentleman did not want to stay at all because of COVID-19, and they were okay with that, and they sent him home, and I was able to follow up with him. So there's actually quite a bit that we can do when we think creatively about how to examine people over phone and video. What if the patient can't use a smartphone? So what if they're just on a landline? Because of the COVID-19 emergency, CMS is allowing an exception to the rule that was previously that many of these encounters had to be done via video. And CMS has basically said, if the senior can't do video, go ahead and do phone, and we essentially won't hold that against you. But keep in mind that there are both federal rules and state rules for medical encounters. And just because CMS, which is a federal entity, says you don't need video, doesn't necessarily mean that that you can do that in every state, because the state rules still apply, and there are different rules in every state. Like the rules for telemedicine encounters in Maryland are different from other states. So I have a link here to the rules in Maryland, and maybe Katie, after this, if you want to send my deck out to everybody, they can click on this to read those rules. And these, one other thing I'll mention is that these rules are changing all the time in every state, especially with COVID-19. So it's not something that's set in stone. What about the primary care provider? So this is a great question. So in my clinic, my role is not at all to replace the primary care doctor. I want all of my patients to have a primary care doctor and to have a strong relationship with them. And in no way do I want to replace that. But what I do want to provide is an adjunct, something to help out when the primary care doctor might not be available. And I have a special skill set. I'm an ER doctor, and I'm really good at helping people figure out whether what they have needs the ER or not, because that's my specialty. So, and unfortunately, because of COVID-19, some primary care doctors have not really been able to adapt to providing telemedicine. So a lot of seniors have been left feeling a little bit abandoned. So to whatever degree possible, I see myself as a stopgap where I can help provide a bridge back to the primary care doctor to whatever extent needed and appropriate. Some of the other issues, I have here some of the key reasons why some primary care doctors have had difficulty providing telemedicine. Some of it is technology challenges on their own end, some technology challenges from patient's side. Coordinating these encounters with staff, the office staff who might be working from home, has been difficult for some doctors. And the rules for billing these encounters are complicated, and some payers are not reimbursing them. So many docs have said basically, screw this, I can't figure this out, I'm just not going to do it.
There was a question, Dr. Mohseni, which is,
Sure.
I'm going to add on to the question as well, but it's perfect timing. So in the case, so there's a primary physician and then someone is using your service, who takes the lead and how does billing work with that? Does Medicare only pay for one or can they pay for both?
Yeah, so what I provide is the same as if you were going to go to an urgent care that's brick and mortar. So there's no restriction. You do not need to give up your relationship with your primary care doctor. You can tell them if you want, you don't have to. The same way you can use your primary care doctor and still visit an urgent care, a brick and mortar urgent care, and still visit the ER when appropriate, same thing applies here. You can stick to your primary care doctor, still see me when you want to. So let's say it's a Saturday night and your primary care doctor is not available and you have some new issue and you just want to talk to somebody or get some advice. That's where I'm available. Just like a brick and mortar urgent care where there's no such restriction, except on my side, you can talk to me without needing to drive to an urgent care. You can just do it from your phone. So these sort of visits are currently being covered by Medicare. So it's essentially, we bill it the same as an office visit. During COVID-19, Medicare is covering these visits. They didn't used to. Pre-COVID, unless you as the patient were in a rural area, so what they call a non-metropolitan statistical area, and unless you were in a clinic or hospital environment, you pretty much couldn't do telemedicine and have it be reimbursed. But now you can, and there have been multiple announcements from Seema Varma, the head of CMS, that they are trying their best to make these changes permanent. And I'm hoping they make it permanent, and I'm keeping a very close eye on these rules. And I think that I would bet money that many of these relaxations of the rules for telemedicine are going to become permanent. This is part of the new way that people expect to get care, and it makes sense, and it helps keep people safe. So these sort of office visits, just like an office visit with your primary care doctor, it's a Part B service. So Medicare original, Medicare will, if you have original Medicare, is going to cover 80%. The patient's responsible for 20%. If you have supplemental insurance or Medigap, that covers your 20% copay or coinsurance, then that 20% will be covered. So then your cost would be nothing. If you have Medicaid, Medicaid has its own rules for telehealth. Essentially, every payer has their own rules for telehealth and telehealth reimbursement. So I don't want to make too many broad strokes, but yeah, either you as the patient or family or caregiver, you may kind of want to go on your payer's website if you have commercial insurance and try to find out what's covered, what's not. But Medicare is covering these visits. I hope I answered your question.
Well, yes. As far as the billing, I did want to unmute the person that wanted to ask about taking the lead and hospitalization to ask you directly.
Yeah, sure.
Okay, let's see, Lindsay. Okay, you're unmuted.
Hi, am I unmuted? Can everybody hear me?
Yes.
Hi,
Yes.
Thanks, doctor. Your practice sounds fantastic. Like it would be a great thing for my 80-year-old dad living in Potomac. My question is, who is then the coordinator and the quarterback? So for example, we call in, dad goes into the ER, he's in the hospital for a couple of days, he comes home. Who then leads follow-up?
Mm-hmm.
Like, oh, I think, the medication is, not working, or he's not ready for PT. Is that you, or is that his primary? That
should be the primary. Okay. That sort of work should be the primary. To whatever degree the primary is not available to provide that sort of care and advice, I can try to pitch in. My specialty is emergency medicine care, so I'm not really the person to come and manage somebody's like diabetes or wounds long term. That's really not what I do, But ER doctors are used to being flexible and figuring things out. So, to whatever degree necessary, I'll do that.
Yeah,
but
we've worked with a lot of great ER docs.
Yeah, it should still be the primary care doctor who takes the lead on that sort of follow-up. if somebody's being sent into the ER, if I'm sending somebody to the ER, then, you know, I'll take the lead on calling the ER and letting them know. And I'm happy to call or message the primary care doctor and make them aware as well.
Okay, and then another question, which I think another caller wanted to know, is what area do you provide services for?
So I'm licensed in 49 states now. So pretty much every state in America except Delaware. I don't know what's wrong with the folks in Delaware.
Okay, okay. That's great. Thank you very much.
Yeah,
You
now
guys can,
I do want to say though that the rules, there are state specific rules. So there are a few states that even though I'm licensed in that state, the rules get kind of tricky. So there's a few states where it's a little bit more complicated. But for the most part, I can provide almost anywhere.
can we call your office to check on specific states, do you think?
Yeah, absolutely.
Talk to
So
Jody?
actually,
Okay.
yeah, so this is actually one of my final slides here. So here's our office phone number. This forwards straight to my cell phone. So, and you can also text to it. Just don't text, you know, PHI type stuff. But if you want to text and say, hey, I have a senior who has an ankle injury, you know, are you available to take a look at this? Or if you want, I have a scheduling system that I've set up where you can self-schedule for appointments. And if you go there and you don't find an appointment that fits your need and you want to see if we're available, again, just feel free to call or text and say, hey, I have something that's urgent. Are you available sometime in the next 20 minutes? And you know, typically we'll be able to get back to you quickly and see if we can figure something out. So feel free to call or text. Feel free to schedule directly online through the website. I've tried to make a relatively easy system. When the senior comes on for their actual video visit, they do not need to have a password or a login or anything to access the video section. All the intake forms are done online where they can basically tap and sign with their finger if they have a smartphone. If they don't, we can, you know, we're flexible and we can basically make it work. And as I say here on this page, you know, we're not here to replace your primary care doctor. We want you to keep your relationship with your primary, but when they're not available or when it's something where it's a potential ER type thing, I'm happy to advise however much I can. And as I said, we do offer remote monitoring of blood pressure, blood sugar, and weight. And that's it. Here's my email address. Feel free to email me if you have any questions. I'm happy to talk to everybody. You know, this is a new clinic that I've started, so we have capacity basically to see new patients. And that's it. I appreciate the opportunity to talk to you guys today, and thank you for Corwood for having me on.
Absolutely. Are you open to answering a few questions?
Absolutely, absolutely.
Great.
Yeah, go ahead.
So one question, in home care and care management, the RNs are not able to diagnose or prescribe as this is outside the scope of the practice. Typically in an emergency situation, we can give guidance and support, but we tend to err on the conservative side of telling the client to speak to their primary or go to the ER. In these situations, is this something that you could help our patients with our clients with if they become your patients?
Absolutely. Yeah, that's yes, exactly. So, you know, it's somebody falls, somebody takes an extra dose of a medication by accident, you know, whatever the issue is, and the primary care doctor is not available, or you think it's a question more appropriate to ask an ER doctor, by all means, that's exactly what I'm here for.
So also, I know that there's a big, when someone goes to the hospital and then they leave the hospital, there's this, within 24 or 48 hours, a huge chance and a big window that there's going to be a rehospitalization.
Yeah.
So would you be a great contact for that person leaving the hospital to kind of, if they're noticing, for example, like an infection of a wound,
Yeah,
or something unfamiliar, they should call, you'd be a great person for them to call instead of having to be rehospitalized.
exactly. And especially, like, you know, a lot of people get discharged on like a Friday, right? This is so classic. You get discharged on Friday evening, and then Friday night or Saturday, like something new is going on. Something's not getting better. Something's actually getting worse. And now you don't know. You were just in the hospital yesterday. you were like, oh, do I need to go back? I don't know. What do I do? My doctor's not available. It's Saturday. It's really difficult to get the attention you need when you need it, you know? So I'm trying to kind of plug some of those holes here and make myself available. Again, so even if it's a weekend, if you don't see an appointment available on my system, just text or call and we'll try to figure it out and make it work. But yeah, absolutely. After discharge from the hospital is it's a high risk period. A lot of things can go wrong. A lot of people do need to go back because they didn't necessarily get all of the care or attention that they needed, but they might feel bad about going back. So this is where, again, I can give great advice as to, wait a second, no, you actually absolutely need to go back. It looks like there's something serious going on, or no, this is actually what's normal and expected, and it's just going to take a little bit more time, you know?
Exactly. A few more questions. For those of us who do need to go to the ER, do you have any recommendations on what we should bring with us or who we should speak to when we arrive?
I think the more you can, one of the greatest things you can do if you are a senior or a caregiver or family member is to summarize your entire medical history on one page and keep that with you. And if you have an advance directive like a MOLST or POST form, staple that to that so that if you ever need to go to the ER, you know, put that on your refrigerator, you can just grab it and go. So what are the things I would put on that? Put your entire medication list, you know, the names and doses of your medicines, your allergies, the names and phone numbers of your key doctors, especially your primary care doctor, and a list of your medical conditions and surgeries, right? So you can put in, you know, high blood pressure, diabetes, you know, this or that cancer, appendectomy, you know, every procedure and diagnosis you've had. And it can just be a list. It doesn't, you know, it doesn't have to be anything complicated. You don't necessarily need a lot of detail there, but medications, allergies, important contacts, which I said, including your doctors, but also including your emergency contacts and family members, right? Your medical conditions, your surgeries, and if you have some sort of advanced directive, a MOLST or POST form, put that all together. That is the greatest thing that you can do so that the ER team has the information they need to be able to assess you quickly. Especially important are things like, are you on any blood thinners? Are you on any medications, especially things like any sort of mental health or psychiatric medications, because they have a lot of potential complications and interactions. Are you currently on any antibiotics? Are you on any heart medications? But really important, like blood thinners. Have you ever had an aneurysm? Have you ever had major surgeries, strokes, heart attacks? One of the common mistakes I see a lot of folks make is, you know, I ask them, you know, so tell me about your medical history. And they say, I have nothing. And then you see they have a med list. They're on 20 different medications. I say, well, what is this? They're like, well, I'm being treated for those. No. I need to know everything so that I don't accidentally give you something that could hurt you. You know, I need to know everything. I need to know all of your medications, all of your allergies. Even, you know, if you had an aneurysm that was repaired 20 years ago, I need to know that, because that might affect how I assess what's wrong with you today. And if you don't tell me the important information, it might make me make a mistake that could hurt you, you know? So it doesn't matter that it was treated 20 plus years ago. Just put everything down on a piece of paper.
Okay. This is a good, and I listened to the podcast about the practice on Mastering Medicare that kind of addressed this. So can you handle a FaceTime call with multiple family members? How does that, you know, kind of work with HIPAA and privacy? Yeah,
absolutely. So technology-wise, absolutely, we can do group chats. I use a system called DoxyMe that allows us to do HIPAA-compliant video chats, including group if desired by the patient. If the patient wants to include family members or other caregivers in the conversation, there is no HIPAA issue there, you know, as long as the patient wants that. That's perfectly fine. And I use a HIPAA compliant video technology platform. In this era, you don't even have to use a HIPAA compliant system. CMS has said if you need to, you can just do it on regular FaceTime. So that's an option if the senior can't figure out our system. But I think our system's potentially even easier than FaceTime. It's really easy to use.
What is that system?
DoxyMe, so DOXY.ME. And if you are somebody, if you are a caregiver, or let's say you're in the healthcare field and you want a HIPAA compliant way to do video sessions, it's the absolute easiest tool I have ever found for this sort of thing. And there's a free version too, doxy.me.
Do you have to upload, so if the family wanted to be in on these calls or FaceTime, would they need to send over any power of attorney or medical documents to you?
Again, it depends on patient consent. If the patient is consentable, so they are with it basically, and they say,
Right.
yeah, I want my family, then no, I don't need any sort of consent.
Gotcha.
But then if the patient is not consentable, it's very helpful to have the right paperwork. Again, if it's an emergency situation, we're always going to do what's in the best interest of the patient and provide the advice that's necessary, you know.
Right.
But if it's not an emergency situation, yeah, then we make it easy for you to share some documents with us. We put it in the medical record, easy to do.
Awesome. Last question. I'm sure there's a cost benefit, right? If calling you and not having to go to the ER, right? Would someone, and this is just my own, I don't have the knowledge that if I were to go to the ER, call an ambulance, there's a certain cost with that, correct?
Right. Yeah.
Right.
I
So
mean,
this would be potentially saving someone some money by not going to the ER.
yeah, I mean, you'd be saving Medicare some money without a doubt. You'd be saving the time and headache of going to the ER. Typically, the ER will involve several hours of, you know, if a senior, we would joke around in residency that, and we actually had this happen once. We had a 100-year-old patient, roughly 100, who accidentally walked into the ER and accidentally registered. She was actually trying to register for like an outpatient thing. And I trained in Philadelphia, where the fear of lawsuits was so high that my attending would not let us discharge her. We had to keep her for at least 6 hours and monitor and all this stuff. The ER is a crazy, crazy place. Lots of things happen that don't make any sense. So if you accidentally walk in the ER, you're stuck there for at least 6 hours as a senior, unfortunately. I mean, that's just, I'm joking, you know, there's a bit of hyperbole here. But yeah, there's a lot of unnecessary time wasted, money wasted. You know, it's uncomfortable. There's loud noises. There's screaming people. You know, it's just, if you don't have to go there, I have no idea why you'd want to go there.
Why you would want to. Now, as far as like, are you able to actually order labs or order PT orders? Are you able to do that also?
Labs yet. I haven't started doing PT. I think that's probably more appropriate coming from the primary care doctor, but we can take that on a case-by-case basis.
But lab work, you are able to
yeah, absolutely
order that. Okay.
Yep.
All right. Well, I know it's 3 o'clock, so I just want to open up if there are any other additional questions that I didn't ask or that you were curious about. What I will do is email everybody and send, is it okay to send the slides, or you'll send me?
Yeah, I'll send you a PDF version that you can share with everybody. Yeah.
Perfect. And also Dr. Mohseni's contact information so that you could reach out to him directly as well. But thank you all for attending. Thank you, Dr. Mohseni. It was extremely informative. This is really such a beneficial practice to have. Thank you. My pleasure. And nice meeting everybody. And yeah, please feel free to reach out with any questions at all. Great. All right. Enjoy your Thursday. Thanks, everyone. Okay. Thanks. Bye-bye.